Good evening, everyone. Today we are going to start skin and bones chapter. I'm going to focus again on the big picture stuff that you need to know both for the field and certainly for passing your examinations, the final exam and the state exam. So first we're going to start with the skin. So as you know, skin is one of the biggest organs in your body, and it has several functions. One of the biggest functions it has, it offers protection, right, from anything from the environment. So any type of bacteria that's trying to enter your body, if you have intact skin, it will be the first barrier of defense. But certainly if you have a broken skin, like you have a cut, then you're more susceptible for entry, right? The other thing skin does, it offers thermoregulation. So we can see the skin here, right? You see all these follicles on the surface, right? And when you get hot, you will essentially form sweat. Sweat will evaporate and you will cool off. So skin offers thermoregulation for you as well. Now there's several layers of the skin that you see here. The top layer is called the epidermis, and usually the top layers of any tissue are going to be called epi, right? Epicardium, epidermis in this case. So epi means the outer layer, right? And as you go down, you will see the layers start to essentially have other structures within them. So as you go down, you'll see the dermis, right, which is composed of papillary layer and reticular layer. And as you go down, you see the subcutaneous tissue. Essentially, here you see the subcutaneous fat. The fat deposits here. This will certainly vary depending on the person. If a person is more obese or has more deposition of fatty tissue, this layer would be thicker. And here we see also, right, your hair follicles embedded. We see arterial supply and supply of veins, essentially to bring nutrients to the tissue cells, right, and get CO2 and bring it back for the exchange. And you have essentially all these small arteries branching out, right, for the supply. Now, so the top layer, right, or the thick skin, they essentially also subdivided into different classification, and you have different stratas of the skin, right? Stratum corneum, stratum macellum, and so forth. And here you have essentially the papillary layer of the dermis. So as I said, the skin has multi-layers, multi-level divisions. And this is in part, right, to offer protection for you, right, from the environment. Now, the other important thing that we're going to talk about is this here is collagen, right? So collagen is not only there for the skin, right? It's a protein, and it's not only there for the fibers of the skin. It also makes up a good chunk of your connective tissue, bone tissue, right? Maybe you guys have heard, right? Those who get or see essentially, right, their skin is becoming not as robust or not as young looking. They may get collagen injections, right, or collagen implants. Essentially, this is what they're using. The collagen is the protein that we're going to talk about, both for the skin and both for the muscle, for the connective tissue for the bone. Adipocytes, as I already said, adipocytes means just the fat cells that you have here. And depending on, again, the person, the amount of them will vary. This is just a close-up view, right? This is on a microscope, and we see the collagen fibers and the elastic fibers that make up the skin layers. And this is the adipocytes, the subcutaneous layer of the skin. Now, why it's important to know the layers of the skin, and essentially what's housed in those different compartments, right? Where's the nerve endings? Where's the blood vessels, right? Where's the subcutaneous tissue? And the reason why the layering is important is that when we get to the clinical component of it and you start to classify different burns, you see, right, you have a first degree burn, which is essentially it's the the top portion, right, you have erythema formation or redness formation. And classically, this is from if you get sunburn, right? Your skin is usually intact in these burns, right? And it's only the superficial layers of the skin that are affected. As the burn severity increases, you go down, right, into your dermis, and even further down into your subcutaneous fat, and the extent of the burn and severity of the burn is certainly much worse, right? And here we see with second degree burn, one of the hallmarks of the second degree burn is you have blister formation, and you see, right, it affects the hair follicles, right? And you have some nerve endings that may also get affected. The third degree burn is going to go even deeper to the subcutaneous tissue, affects the arterial supply here. And here, there's another diagram just to give you an overview of the skin layering that I talked about and the severity of the burns. So here we see the first degree burn, which is on this side. It pretty much extends to the epidermis, or as I said, the outer layers. And the classical example is the sunburn. And then the second degree burn, I'm going to show you that there's subdivision. They have subdivided further. So you may have a deeper second degree burn. But the importance of this, right? The importance of this is, you see, right, the lower you go, the more structures you essentially take with you, right? Now, the second degree burn, as I said, the hallmark of second degree burns would be a formation of blisters. And third degree burn is usually you see sloughing of the skin, and I'll show you some pictures with that. Some books will have a fourth degree burn, and fourth degree burn essentially it's like to the bone. The American Burn life support course, they only have it up until third degree, I believe, but there is some books will have the fourth degree burn, so it's just to the bone. Now, so we said, right, first degree burn is the superficial layer of the skin, essentially the top portion of the epidermis, and you have the erythema formation. Usually the skin itself is not broken with this. And there's a very important clinical hallmark about the first degree burn here, right? Does anyone know what's so special about the first degree burn when it comes to a clinical application of it?
It is more severe because it has the nerve ending of the nervous.
So the first degree burn is not more severe than the other burns. The hallmark, I will give you a clue. It has to do with rule of 9's. Does anyone know what's so special about first degree burns and the rule of 9's?
When you're like deciding whether to go to a burn center or not, if it's a first degree burn,
yeah,
you need more of it for it to be considered like a burn.
Okay, if I'm okay, so how about this? I'm gonna say your chest, the entire chest area and abdomen is about 18% on rule of 9's. And let's say I was sunbathing and I was laying, on my belly, and my entire front and my belly got sunburned, right? I got the first degree superficial burn. If I was using the rule of 9's to calculate my body surface area, how much would I write down on my ACR if I was recording it? So we said the chest and the belly got first degree burns. How much would I record for rules of 9 for that?
If it's just the chest and belly, be 18.
18, right? So good that you guys say this. And in terms of the sizing, you would be correct. But in terms of rule of 9's, you will not be correct. The reason being is that for the first degree superficial burns without blister formation, which is essentially blister formation we get to the second degree, right? Those areas are not included in total body surface area calculation, right? So we will not factor this into our rule of 9's when we do our calculation. So remember, what's so special about the first degree burn is that they do not get factored into the whole burn rule of 9 criteria. You're going to learn later in the course about Parkland formula, which is essentially how much fluids you're going to give a burn patient based on the total body surface area that they sustained burns to. And what you got to remember is first degree burns that do not have blister formation do not get calculated into your formula. So that's very important, right? So when you get a burn, a few things that the skin provides, are under jeopardy now, because the skin was burned. It received the thermal, essentially scorching from the burn. And now the problem is the thermal regulation that we talked about, the sweating, right? Evaporation is not so great. Also protections from infection. So now if you are having, blisters that rupture, now you have communication, right, to the environment. So you now are more susceptible to the infection. That's why we teach you guys to employ sterile sheets. And the reason for the sterility is that you want to prevent any type of bacteria, basically coming onto the skin and making contact. We talked about also using sterile burns dressing, right? And you also will have issues with fluid and electrolyte balance, right? When skin is a huge part, and it's one of the biggest organs I told you about. So all these things will be affected depending on the severity and the degree of the burn. Now, I'll show you some pictures. This is essentially from ATLS, Advanced Trauma Life Support course, and they further subdivide in the second degree burns that have blister formation. Here you see the blisters right at the top. They have superficial partial thickness and they have deep partial thickness. So it doesn't extend all the way down to the bone. This is the second degree, as I said, right? Should not really go down to the subcutaneous layering. However, the difference being is, if you notice this term superficial partial thickness, it's usually second degree burns. They definitely have blistering. They're certainly going to be painful, and they will glisten, as you see here, right? The glistening of the skin. And the deep partial thickness, right? They're essentially going down more into the dermis layer and mottling, right? That's pictured here, right? And at the photo D, this is a full thickness burn. So this will be your third degree burn. So this is your second degree burn, right? This would be a third degree burn. And the distinction between superficial partial thickness and deep partial thickness is that in a deep partial thickness is basically extended further into the dermal area. And the skin may be more mottled and may not blanch, right? So this is the rule 9's that we talked about. This is essentially going to be one of the most important things for you to remember when you're dealing with the burns. You're going to be using it to calculate your total body surface area. You're also going to be using for your Parkland formula when you calculate fluid resuscitation, right? So for adult person, the head, right, front and back makes up 9%. The chest is essentially, the chest and the abdomen makes 18%. The back makes 18%, so the torso makes 36%. The arm anterior and posterior surface makes 9%, and the legs anterior and posterior surface, right, makes 18%. This is 36 front and back. Now, the distinction between adult and pediatric, you notice the best way I can describe this for you is that you take area from the legs, right? You take from the legs and you put it to your head. And the reason why is that pediatric patients have bigger heads as related, right, to overall of their body, and their legs are smaller, right? So you see, right, 7 and 7 for each of the leg, essentially, right, front and back, which will be 14%, and 2.5% for the buttocks area. So next time, if you're taking the test, what you want to do is remember, right, take roughly, right, 4% and from the legs and put it to the head when you're dealing with the pediatric patient. So their head is the bigger size. This I would definitely study. I would definitely print this out and calculate different areas. You will definitely see questions for that for your future exams. right? The next thing I want to talk about the skin is cyanosis, right? Does anyone know what's the cause of this? And if you have watched the prior lecture on respiratory, that should give you a clue in terms of what causes cyanosis.
Hypoxia.
Hypoxia, can you be more specific?
There's no oxygen in the blood.
No, so you're
Or-
yeah, you're almost there, right? So essentially, so the reason what this is hemoglobin is in its deoxygenated state. So there is no oxygen loaded to the hemoglobin, and this will showcase as bluish tinged when the heme is bound to oxygen. That what gives it its red coloring, right? So we see that, you know, good perfused skin when the hemoglobin is fully bound to oxygen. But when hemoglobin is not bound to oxygen, we see this formation of cyanosis on both the hands, right, the extremities, and also you may see what's known as circumoral cyanosis, basically this types of blue tinge around your lips. That should signify to you, right, as a clinical sign that a patient is in fact needs oxygen, and you need to be essentially providing oxygen via non-rebreather mask or BVM, depending on, you know, their tidal volume and the ability to move oxygen. But this is another clinical tale, right, to give you an idea, right, of patient status. So skin can show you some clinical, right, relevancy in terms of this. Also, just to give you another perspective, right, we see bruising that on the skin, and what essentially what the bruising is, it's when the red blood cells hemolyze or they break, right? And you have something coming in, right, from the macrophages, which are big eaters. We're going to learn macrophages are essentially white blood cells made by the hematopoietic stem cells in your bone marrow. And when they phagocytize, right, these red cells, you have byproducts, right, of bile pigments and hemosiderin, and this would causes, you know, you'll see the bruising, and it doesn't have to be just by the eyes, right? It could be anywhere else in your body, right? So skin functions, right, to show you clinical signs that the patient may be having, right? The other important thing that the skin has is it absorbs sunlight, and we need that sunlight, right, for activation of essentially vitamin D. In the wintertime, if you go to your doctor, they'll check your blood work, your vitamin D level is reduced, and they will often tell you to take a supplement, right, vitamin D supplement. And the reason for that is especially in wintertime when the sunlight is, you know, shorter, right, shorter daytime, and you're covered up, right, bundled up in your clothing, very minimal sunlight, you know, goes to your skin. But we need that sunlight, right, to essentially activate the calciferol through the liver and the kidney function, and then get the functional vitamin D, right? So this is another function of the skin, right, for making effective vitamin D. The other thing I kind of talked about, it's in terms of thermoregulation, but the essentially what types of thermoregulation do we have? The first one is essentially it's radiation. And radiation is you basically emitting heat energy. A good example, if you go in very cold and you're breathing air, you'll see your breath is seen right on this cold air, right? There's like it's almost like a steam coming out. So radiation, you radiate your heat to the atmosphere, right, or to the environment, to the cold environment. In conduction, you have a physical connection to some sort of an object. So it's a transfer of heat from skin to an external object. So let's say you you know, come out and there is a metal bench, right? You're waiting for, let's say, a bus, and it's very cold. You come, you sit down on this cold metal bench, and it will pull the energy from you through conduction, right? Convection is essentially, this is what you experience in the summertime, right? If you have sweat formation, and if you stand by the fan, right, and it blows on you, and by convection, it essentially it's flowing away from your skin, so you get cooler through that. Evaporation is you get cooler by the sweat just basically evaporating off your skin, right? So the heat is beaming on you, and sweat that you make evaporates. So this is just 4 mechanisms of the way you will can exchange heat, right? Either lose heat to the environment through these processes, right? So radiation, conduction, convection, and evaporation. And all of this is certainly through your skin, right? The other thing I want to touch upon, right? We talked about different layering, right? So we said we have epidermis, we have dermis. As you go deeper, you get to the subcutaneous tissue, and below that we start to get into your muscle tissue, and then your bone tissue. So I wanted to ask you this question, right? So imagine you have a patient, right? So you have a patient who is showing signs and symptoms of anaphylaxis. So let's say he got stung by a bee, right? And we're going to say he has all of this. He has respiratory compromise, right? He is wheezing, he has dyspnea, he has reduced blood pressure. So to the skin, right, the perfusion is diminished, right? So when you have low blood pressure, the body wants to save all that blood flow to your essential organs, the heart, right, the brain, and the lungs certainly, and not to the skin. So your skin is poorly perfused, right? That's why we'll see they'll have cooled, clammy skin, right, and diaphoresis. And also, in addition to that, right, the patient is showing signs of respiratory compromise. They may have involvement of the skin, urticaria, some GI complaints they may have. But at the main point that I want to make is they have respiratory compromise and they have reduced blood pressure. So they have anaphylaxis. All right. So EMT comes along, right? And he knows that for an adult patient, I got to give epinephrine 0.3 milligrams. And he selects a syringe, right? That, their company provided, but he wasn't really sure of the size and length of the needle he has to use. So let's say this company buys a bunch of insulin syringes to give insulin, and he goes and pulls up 0.3 milligrams of epi, and he goes and administers it to the patient into the subcutaneous tissue. What would be the problem with that?
Insulin syringes are like 0.5 milliliters for like the whole syringe, so you'd have really hard time estimating your dose.
Let's say he pulled up the right dose. He pulled up the right dose.
You're in the fat.
You're in the fat. Who's saying that?
And then gonna be absorbed by
Ian.
the blood.
Yeah, this is an IM injection, and it's not a subcutaneous injection.
Excellent, right? So Ian is right. He's like, you're in the fat, right? So I just explained to you, right, the problem. The skin is not getting perfused well, right? So the blood supply is now being directed towards the vital organs. The skin is poorly supplied, right? And you're going ahead and you're administering a medication into the fat, right? But where do I want to give that medication to? I want to give this medication into the muscle, right? I want to give this medication into the muscle. So this is the IM injection here. And you notice, right? When I'm doing the IM injection, I'm going to go bypassing the dermis, the epidermis, right? The subcutaneous tissue, which is essentially fat. And I want to get into the muscle. And why is getting into the muscle so critical for patients like these?
Because the muscle is rich with blood supply. That's gonna get it.
Excellent, right? So I want the blood supply, right? I want that blood supply that goes through the muscle so that medication is absorbed and delivered quickly, right? And becomes systemic. I want it to go systemically, right? And circulate through the entire body so that right, I correct the problem. So knowing the layering of the skin and the size, I want to say more the length of your needles becomes vital, right? So this is from a syringe company, right? A BD syringe company, and the sizing may be slightly off from your book, but overall the point still holds. So you'll see here, right? So for your subcutaneous injection, which is usually we inject, right, in the hospital, we inject heparin or insulin for slow absorption. You'll see the sites, but more importantly, you'll see the length of the needle, right? So the length of the needle, let's say if we look right here, right, all of them are less than an inch, right? 1.5 inch or 5 1/8, right? That you see here. But for an IM injection, right? If I go to for an adult person, right? If I go for needle length, they're 1 inch or greater. And the reason why you need the length is that you need to penetrate all these layers to get to the intended site. And if you don't do that, right, not only you're not going to see the medication working, right, your patient will continue to show, all the effects of their pathophysiology of the disease process, and you're not correcting the problem at hand. So knowing the layers of the skin becomes very important. The other thing that I want to say, as I said, right, different individuals may have different amounts of subcutaneous tissue. So they may have more or less. So if you have a very obese patient, right, and you're trying to get to the muscle, maybe you need to use the needle on the longer side, right? Maybe you need to select that 1.5 length, right? This also becomes important later on when we get to the bone. I'm going to show you guys IO intraosseous, right, needle that we essentially drill into the bone, and the amount of fat a person has becomes also very important. If you don't get the right size needle, right, the right size length, you will essentially drill into the fat, and all your medicine is going to be infusing into the fat and never gets to the intended site. So this is just of the takeaways, right, from the skin for you guys to keep in mind in terms of the layers, how they affect the selection, for example, of your catheters, right, and your needles for the injections, and also when you classify burns, right, how to classify it so that you get correct body surface area for your calculations. So remember, for the burns, the first degree, right, or the superficial burns do not average into your calculation. Those burns that show formation of blisters and that mottling type of appearance, right, or they're past that to the 3rd degree burn, yes, those are that you are calculating into your formulas.